We use the 3-drug regimen, and on top of that can offer olanzapine.
Dr. Javeri, are you using the 4-drug or 3-drug antiemetic prophylaxis? What is your approach to managing nausea?
Absolutely. It's been a game changer, actually. Trying to ensure that we use the 3-drug regimen, and on top of that can offer olanzapine as the 4th drug has really, really helped manage nausea in clinic, which I agree is the most frequent toxicity that we face actually with T-DXd. And while we worry about ILD pneumonitis, thankfully it's a little lower, but of course the vigilance has to be higher given what it could do in terms of outcomes, including fatal outcomes that can happen. But I think nausea management is really, really critical because that's your day-to-day toxicity, and it's a modifiable or a preventable or a toxicity that you could provide supportive care for. So I think making sure that our patients are taking it and making sure that they're reporting it back to us so we can do something about it. Fatigue is a very interesting toxicity, and I completely agree that, you can see that with T-DXd as well. But I also feel like we as doctors, as our clinical care teams, need to probably probe into the fatigue a little bit more, which we don't necessarily do a good job at necessarily all the time. But it is subjective in some patients, right? And we need to get a sense of what is the level of fatigue that they're referring to. Is it really impacting their activities of daily living? Is it something that they're facing, but they're able to continue to do their, daily livings? And that can have an impact on how we want to modify the dose for a given patient in clinic. So that is something that I think we can do a better job at assessing this otherwise subjective toxicity, and we really want to do a better job at that. I think one thing I'll also add is alopecia. And when we had our late-line trials with T-DXd, certainly the alopecia rates reported were much higher. And so while I'm starting a patient on T-DXd, I certainly talk about alopecia all the time, but I'm sure we all have appreciated the fact that fewer patients actually land up having higher grade alopecia, and most people actually land up keeping their hair. And so I probably scare them a lot more than what actually I see in clinic, which is not a bad thing. I'd rather do that than not. And then some patients always ask about scalp cooling, and we're still trying to understand. I mean, these are longer half-lives. These are, antibody drug conjugates, which are different than our other agents. But if a patient is wishing to do that and wants to try that, we have trials ongoing addressing the question, but I don't say no. I just make sure that they understand we don't know if they are keeping their hair because of the scalp cooling or because they would have otherwise never lost it anyway. So I think I've kind of kept that approach in clinic for alopecia, and that has helped. And in addition, for the patient education for grade 2 ILD pneumonitis, which is reporting cough, which is very, very important to discontinue therapy, I think it's also our vigilance of looking at scans more carefully and reports more carefully, because it's the asymptomatic grade 1 ILD pneumonitis, which we can easily tackle in terms of holding drug, giving a short course of steroids, and maybe rechallenging. We've seen some rechallenge data as well. And keeping a patient on therapy, especially if they're benefiting really, really well. So we as a community have gotten a lot more vigilant with this, reviewing this, because we see pneumonitis with PI3K mTOR inhibitors. We see pneumonitis a little bit with CDK4/6 inhibitors. And certainly we want to keep an eye because of what we've seen with T-DXd in other trials. So it's about 12% is what we're seeing, 10 to 12%, and we want to continue to be vigilant about that.